Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Madrigal Pharmaceuticals.
Hello, I'm Dr. Robert Brown. I'm the Vincent Astor Distinguished Professor of Medicine and Chief of the Division of Gastroenterology and Hepatology at Weill Cornell Medicine in New York. Welcome to this Medscape program entitled The MASH Countdown. I'm very pleased to be joined today by Dr. Kimberly Brown, who is a professor of medicine at Wayne State University and Michigan State, and Associate Director of the Henry Ford Transplant Institute in Detroit. Welcome, Kim.
Hi, Bob.
I'm excited about the discussion today. We're doing a quick fire format. We will ask each other a question and we'll have just 60 to 90 seconds to respond. And maybe time for a short rebuttal if we disagree on anything, which I'm sure we will. Let's get started. Kim, first question to you. What are the primary risk factors for MASH that should prompt screening? You get 90 seconds for this one.
Well, I'll try to keep it there. So I think our understanding of MASH has really changed to one of sort of a participant in metabolic disease. So we really see this in patients who have other metabolic conditions, diabetes, hypertension, hyperlipidemia, obesity, sleep apnea. So the patients that you're really focused on are patients with those metabolic conditions. We can see that several guidelines include who to screen. All guidelines suggest that patients with type 2 diabetes, over 50% of patients with MASH have diabetes, so those are a high-risk population. So any patient with diabetes should be screened, but the reverse is also true. Patients who have MASH or MASLD should be screened for diabetes because of that sort of bi-directional thing that happens in metabolic conditions. So I think those are the people that I would screen primarily.
As a follow-up, I mean, obviously you highlight the obesity and diabetes. They may not be in a GI practice. Who should be screening patients for MASH? What specialties? And try to keep this one a little shorter. We only want to do this one in 60 seconds.
No, it's a great question. So if you think about those metabolic conditions, where are they? They're landing in primary care offices and endocrinology offices. So from the primary care standpoint, any patient that they're seeing for any of those metabolic conditions should be screened. And in endocrinology offices, anybody with diabetes should be screened. And actually, that's a recommendation from their society now as well. So now it's my turn. So, Bob, what non-invasive tests for MASLD/MASH are preferred in these different clinical settings? And you only get 90 seconds, so be quick.
So I think we have to divide them into two sets. We have our serum biomarkers, which can be done in almost any setting. And then we have imaging, which generally will require referral to a specialist, but not always. So I start with FIB4, and FIB4 is available from our routine laboratories. It just includes our liver function tests, platelet count, and the patient's age. So this can be calculated, and often Epic will calculate it further. There are others that you can use, but I think for the high-risk populations, and you highlighted the type 2 diabetics, the ELF, or enhanced liver fibrosis, has become the secondary go-to blood test. There are some specialized scores, but I don't really use them in my clinical practice. And then I think the next step, if the FIB4 and ELF are worrisome, is to go to an imaging-based test, of which transient elastography has been the most validated and probably the least costly, but also you can use MRI or MR elastography. So the consensus is that we are going to use the FIB4 as our initial screen and then either VCTE or ELF to follow up. And these have been put into guidance documents, both from our liver societies as well as others, that have suggested using the FIB4 as the first screen. And if it's below a certain cutoff, they stay in primary care, generally viewed as 1.3. And then if it's higher, they go to specialty care. Though I think in people who have a high number of risk factors, particularly obesity and type 2 diabetes, we may want to use a lower cutoff to get a secondary assessment. In particular, I use ELF. So that's my approach. What do you do, and how do you time these tests? Which order do we do the non invasive tests, both in your practice and in our guidelines?
Yeah, it is a great question. And as you pointed out, FIB4 is really the test that is recommended by almost every guideline to be used in the primary care setting. It's easy, it's non invasive, it's easily calculated looking at your phone with some equation. And that, that can help risk stratify patients. What I find is that most commonly, those are the patients that are just referred on, right? Patients who have an intermediate or higher one, they come to us. And then, as you pointed out, a secondary test, I tend to use transient elastography, but others may use ELF. What I like about the AGA guidelines is that they start by telling you to rule out other causes of liver disease. And I like that as a reminder in the primary care setting. And then also, they highlight, I think, a little bit more strongly the difference between those patients who have other metabolic conditions and those who don't, both in terms of when to sort of go on to the next step or also how closely to follow those patients over time. And again, the same tests that you described, the FIB4 to start, and then L for transient elastography. Certainly MR elastography or MRI PDFF can be used. Lots of data in the literature, but they're just not commonly available for practitioners.
So, given all these NITs, are there any MASH patients for whom you would still do a liver biopsy in clinical practice outside of a clinical trial setting?
Yeah, absolutely. I mean, I'm old enough that we can recall the days where patients who had steatosis and hepatitis, either hepatitis C or hepatitis B, they didn't do as well. And I think we understand now that many patients who have PBC, PSC, autoimmune hepatitis may have either coexisting steatosis or may have separately MASH. So, patients who are treated potentially for other forms of liver disease who don't normalize their liver test, that's a biopsy situation. Those patients where I'm considering they may have two diagnoses or even I'm unsure of the diagnosis, they have additional testing. And then finally, when the non invasive tests don't match up, I can't get them to be consistent, then I need a biopsy to determine sort of degree of fibrosis.
So, seems that it's clear that we don't need biopsy for staging only, unless our NITs don't agree. It's for diagnosis when either the diagnosis is unclear or there may be two diagnoses. So we've made our diagnosis, we've done our staging. Let's switch gears and talk about MASH treatments. We now have two FDA approved therapies, resmetirom and semaglutide. What are the indications for these treatments, and which patients would you select for one or both of these agents?
Certainly. Well, as you know, just to remind our audience, resmetirom is a thyroid hormone receptor beta agonist that was approved actually in March of last year in patients who had MASH, so that's steatosis with inflammation, with moderate to advanced fibrosis, so that F2 to F3 patient. More recently, in August, semaglutide, which is a GLP-1 receptor agonist, was FDA approved really for the same indication, those patients with MASH as well as F2 or F3. So those patients with moderate to advanced fibrosis. And there's lots of benefits of these therapies. Really, the goal of any liver-directed therapy is to prevent progressive disease, right? So anything that we use is really used to try to prevent further progression of inflammation and fibrosis. There are many indications, though, for GLP-1s in MASLD. Those patients who have type 2 diabetes, certainly it can be used in those patients alone, but also in those patients who have obesity, those patients with BMI greater than 30, or those patients with a BMI greater than 27 with multiple metabolic conditions. So the GLP-1s can be used. They have indications outside of MASLD, whereas resmetirom has an indication primarily for MASH. And when we look at who we select for treatment for these individuals, again, I reminded you and the audience that it's really those patients with F2 or F3 disease. So I try to help our fellows understand who do they use it for. Well, those patients who have moderate to advanced fibrosis. So for me, I use a elastography with a KPA greater than 8. Um, in those patients who have advanced disease. And for me, I use a KPA greater than 20. Those patients I think would be a contraindicated because they're closer to decompensation. Those patients who are kind of in between a KPA of 15 to 20, I use my clinical judgment. Certainly, these are not yet indicated in patients who have more advanced disease, cirrhosis, or decompensated disease. When we look at those patients who are being treated in an endocrinology clinic, I think they take a much more holistic approach, which I think is really advantageous. They start with lifestyle intervention, which we should be doing for all of our patients. And then they really focus on the ways that these GLP-1s can be used. They can be used for obesity, diabetes, or for MASH. And you can understand that in certain cases, you would want to use these medications for all three. If the patient just has diabetes, then you're using it for that. But if the patient is obese, these medications often cause weight reduction, but also now indicated for MASH. So really the sweet spot is those patients who have metabolic disease, type 2 diabetes, maybe extra weight, but also have underlying liver disease. So I'm going to flip it back to you, Bob. What about patients who are already on a GLP-1, right, for cardiometabolic reasons? So lots of patients in endocrinology clinics are on these drugs. Do you still screen them and risk stratify those patients for MASH?
Yes, of course, we need to because one, if they have advanced fibrosis or cirrhosis, they're going to need HCC screening and liver directed care. And I don't think of GLP-1s and resmetirom as an either or phenomenon. Neither of them has 100% response rate. And I think many of our patients are going to need to be on both. So if a patient is on a GLP-1, and still has F2 to F3 fibrosis and has hit their target for their weight or their hemoglobin A1C, I would consider adding resmetirom. And it's important to know that in the resmetirom registration trial, 15% of patients were already on a GLP-1. So I think if you can start with a GLP-1 if you feel confident, but you may have to add resmetirom. So do you add as resmetirom if someone's already on a GLP-1, or you say, well, they're on a GLP-1, I'm just going to give them more time?
Well, I think to your point, and I agree with your approach. Many of these patients already come on a GLP-1 and they've been on a GLP-1 for a period of time. But certainly, once they've been on a GLP-1 and achieved whatever benefit they've had with respect to weight reduction and glucose correction, I will risk stratify them. And absolutely, resmetirom is really a liver-directed therapy, so it works very differently than GLP-1s. And yes, I would consider adding it in a patient who hadn't had a good histologic or non-invasive testing response.
And I guess the reverse might be true as well. Someone who's on resmetirom who needs weight loss and better diabetic control, we could add a GLP-1.
Yeah, I agree. So, Bob, back to you. How do you monitor patients on resmetirom for response? Are there any specific adverse events that you talk with your patients about or monitor for?
I think that let's start with the monitoring. I think we have to monitor the patient's liver function tests, and I do it every 3 months. if you do check on resmetirom at 1 month, often the ALT will rise transiently and then fall. And that's important to know. And then I check thyroid function tests and lipids probably every 6 months. And then I think the important thing is that the imaging changes, both in terms of VCTE, will take longer. And so I will not monitor that for at least a year. And then the real things to worry about is most patients will have mild GI side effects. And that's the other reason I won't start a GLP-1 and resmetirom at the same time, because they both have GI side effects. There was one rare case of a drug-induced liver injury with resmetirom that we need to warn patients about. But more importantly, they will increase their statin exposure. And so there are recommended statin doses for resmetirom, and you do have to warn them about muscle aches and to be checked if that happens. But in general, this is really well tolerated, but does have some GI side effects. What about semaglutide? What is the monitoring strategy there?
Well, I think when you look at the side effect profile and the monitoring, again, GI side effects are the most common things people complain of. You can see, according to the literature, increased heart rate, which I've not seen. But you have to monitor blood sugar, particularly in those patients who have diabetes. But the one thing that I would suggest monitoring is actually for muscle loss. This is not something that's well described yet in the literature. But in patients who have rapid weight loss, they lose muscle as well as fat and can become increasingly frail. This is particularly problematic in older patients or patients with more advanced liver disease. So I think that's the biggest thing I monitor for now.
Well, Kim, our time is up. This was a great back and forth. I had fun. I learned stuff. Thank you for joining me in this expert quickfire. And thank you, the audience, for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.